So hello and welcome. I'm Heather Cronus-Danek, Senior Director of Development for Individual Giving for the Eye and Ear Foundation. The Eye and Ear Foundation supports the two world-class departments of Otolaryngology and Ophthalmology at the University of Pittsburgh School of Medicine. Our fundraising efforts support wonderful projects and research in both departments, including glaucoma, head and neck cancer, hearing, and today's topic, allergies, which I think we can all relate to. I know that I can right now. So a few housekeeping tips before I introduce today's speaker. Chat is disabled, so no chat. Please submit your questions via question and answer. If possible, please refrain from personal medical questions. However, if you do have them, send them to our contact info at Eye and Ear, and we will have Dr. Hathaway attempt to answer them for you. So today, talking about spring fling, an update and evaluation on allergies. It's my honor to introduce Dr. Bridget Hathaway, Assistant Professor of Otolaryngology and the Director of the Allergy Department at the Department of Otolaryngology at the University of Pittsburgh School of Medicine. Dr. Hathaway, welcome.
All right, thank you. Thanks for joining us to talk about this, timely topic of allergies in general, but particularly spring is upon us. So we'll get started here. Okay, so we'll jump right in here and talk about, why do we have allergies or any of these issues? It comes down to the immune system, as with so many of diseases that we're faced with. The immune system's responsible for, recognizing self versus non-self. And it's a combination of responding to threats, be it in the environment with, infectious agents, or even in our own bodies. The immune system is constantly surveilling for cancer cells and responding to those. And so you need to have an appropriate response to threats. But then on the other hand, the immune system has to tolerate things that aren't a threat. And that would be our own bodies, our own tissues, or things in our environment that aren't a threat. Now, when you have a breakdown in any of these pathways, if we don't tolerate our own tissues, we end up with an autoimmune, in the autoimmune disease kind of realm. When we don't tolerate some of the benign, non-threatening things in our environment, that's when allergy becomes a problem. So allergies, if you think your allergies are getting worse, that's entirely possible. And one of the things that's fueling that change is climate change. So this year in particular, we had a particularly warm winter in the Northeast, at least. That's responsible for plants and trees blooming earlier and for a longer period of time. That means more pollen in the air. Increased carbon dioxide levels also enhances photosynthesis, causing plants to release more pollen into the environment. Then when you combine that with pollution, the particulate matter in pollution also stimulates inflammation. And so when you have that inflammation added to the allergic response, it's a synergistic effect, and it enhances the any allergy symptoms that someone might have. Allergies are incredibly common. As you all know, if you don't have them yourself, you almost certainly know someone close to you who does. It's about 8% of the adults in the US have hay fever. Almost 10% of children have reported hay fever symptoms in the past 12 months. This data is going back a little bit to 2012. And 11 million doctor's office visits resulted in the diagnosis of allergy in a single year. So that's a lot of medical attention and intervention required for allergy symptoms. Food allergies, not really going to touch on that in this topic or in this talk, just given that we have a relatively short amount of time together. But food allergies, as you might know, have also become more common. Why are allergies becoming more of an issue? We think it has to do with, our one thing is the lack of exposure to other things early in life that basically train the immune system and about how to react. So you might have heard of the hygiene hypothesis, which was first introduced by David Strachan in 1989. Now, he didn't use the word hygiene hypothesis, but his theory that reduced exposure to various microbes in dirt would make a person more prone to allergy. And that was the paradox. So as we've seen in the modern era, clean drinking water, sanitation, vaccinations, advances in medicine have made us much healthier in many ways. However, allergies are becoming much more prevalent, and particularly in the industrialized and urban parts of the world where all of these sanitation and medical advances have been most prevalent. So what happens with all these advances? They lead to less exposure to infectious agents during childhood. That's a result of vaccinations, antibiotics. Of course, now more than ever, we're inundated. We're constantly surrounded. I mean, try walking by a counter without a jar of hand sanitizer in almost any public place these days. So all of that obviously has some positive results in terms with infection control, but the flip side is our immune systems aren't exposed to as many of those diseases and agents. So the other thing, it's been well studied that the number of older siblings, so more older siblings, less likely to have allergies when someone gets older. Likewise, daycare in the first month, in 6 months, infants who have been in the daycare in the first 6 months of life also have a lower risk of developing asthma and eczema later in life. Children who grow up on farms, 3 times less likely to have allergies. Unpasteurized cow milk, also some protective effects. And parasitic infections, not too many of those, also well known to be associated with the loss of protection from allergy throughout life. And this comes down to our immune system. There's 2 main pathways in the immune system in terms of responding to various threats. And it's going to be pretty broad here, but there's a Th1 and a Th2 pathway. And they're responsible for responding in different ways to threats from diseases or neoplasia, but they need to be in balance. And when they're out of balance, it leads to problems in either direction. But when the Th2 response is the predominant, becomes the predominant phenotype, that's when we see a predisposition to allergic diseases, including asthma. So there's a whole range of allergy-mediated diseases. Today, we'll be mainly talking about allergic rhinitis, which refers mainly to nasal and eye symptoms. Oral allergy syndrome more has to do with obviously mouth symptoms. Definitely some overlap with allergic rhinitis. Asthma can be an allergic mediated process. Eosinophilic esophagitis, involving basically an allergic inflammation in the esophagus. Atopic dermatitis affecting the skin, and then also food allergy. So the common thing with all these things, it's any of the skin surfaces, nasal cavities, lungs, GI tract, any part of the body that's basically exposed to the outside world, be it through, inhalants or foods, is a potential target for allergy symptoms. So in terms of allergy symptoms, runny nose, cough, postnasal drip, epiphora, that means watery eyes, voice symptoms including hoarseness, throat clearing, facial pressure, nasal obstruction is associated with sleep disturbance, and all of this results in fatigue. But those symptoms aren't specific to allergy. There's a lot of overlap between those symptoms and a lot of other disease processes, particularly that we see as otolaryngologists. And just in terms of causes of rhinitis, we have allergic causes of rhinitis and non-allergic causes of rhinitis. When we think about allergy, it can be divided into either seasonal or perennial symptoms, or intermittent and persistent, different ways to categorize allergy symptoms. In terms of non-allergic causes of rhinitis, a lot of these are very common. Vasomotor rhinitis, that's basically a runny nose triggered by cold or exercise, or non-allergic things. That's a very common cause of a runny nose, particularly in older adults. Irritant-induced rhinitis, very common with tobacco exposure, also occupational exposures, whether it's construction, painting, bakers, anyone that's inhaling particulate matter or exposed to chemicals on a regular basis would be at risk for that. Infectious rhinitis, think of the common cold. Drug-related, there's a whole host of drugs that have been implicated in nasal inflammation. The most common one we think of is Afrin, but there's many others. Hormonal, where you may have heard of rhinitis of pregnancy, but then other hormonal fluctuations can also lead to nasal inflammation and congestion. Gustatory rhinitis means runny nose, basically caused by eating. Oh, sorry, this picture, this little picture transposed in a bad spot here. This just, in allergy, you need to have an antigen to trigger an allergic response. What happens, and you need to have repeated exposure. So you can't have an allergic response to something you've never been exposed to before. So we'll think about ragweed. You have to be exposed once. You're exposed, your body responds, your body makes these immunoglobulins. This IgE immunoglobulin is the one that's mainly responsible for the allergic response. So your body's going to make all these little IgE molecules in response to the ragweed. These IgE molecules are presented, they're on this mast cell. The next time ragweed season comes along, the antigen, we'll call this the ragweed antigen, is recognized, and it binds to these IgE molecules, immunoglobulins that the body produced the year before. It causes this basically activation of this cell. This cell releases all of these inflammatory mediators that are responsible for the allergic response, including asthma, hives, nasal congestion. Just a picture of what a nose, this is normal nose here on the left side. You see the nasal mucosa has a nice kind of pink, thin appearance. This is the nasal septum here on this right side. This is the inferior turbinate. This is the middle turbinate up here. They're all normal nose structures. And you can see a nice little airway in here, a nice little air passage for air to get all the way back to the nasopharynx there. This is what allergy does to the nose. You see the mucosa is pale, it's boggy. It's wet because it's producing extra mucus. These turbinates, you see how it's nice and kind of just much smaller over here. This is the turbinate, except the mucosa over. It's completely swollen, boggy. It's touching the septum. You don't see much of a nasal airway in here. So that's what that would be what a really allergic nose looks like. Not going to get too into the weeds here in terms of the chemical mediators of allergy, but I am going to mention histamine because it's really the most important one. The mast cells and basophils, those are the cells in the body that produce most of the histamine. And for someone whose system has been primed, those mast cells and basophils, lots of them are just sitting there full of histamine and waiting for that antigen to come, trigger the activation and release. The histamine response starts at about 5 minutes and peaks at 30 minutes. So the onset's fast. Ask anybody with a grass allergy who goes out to cut the grass. Histamine causes symptoms like itching. The increased vascular permeability means that fluids, the fluid's more likely to leak out of the blood vessels, and that leads to the edema, meaning nasal congestion, airway edema, hives. Increasing heart rate is another, side effect of the histamine. Histamine also triggers the goblet cells, which are the little cells that line the airway that produce mucus. So histamine increases mucus production both in the nose and throughout the airways. Smooth muscle contraction in the bronchial tree is responsible for wheezing and the asthma symptoms associated with allergy. And there are histamine receptors throughout the body. And we talk about, histamine, different effects of histamine, but there's histamine receptors in the brain, the blood vessels, the heart. This is the bronchial, so the airways and the little bronchioles and the heart. So there are H1, H2, and H3 receptors. The H1 receptors are the ones that are really most active with the allergic response. You might have heard of the H2 blockers. Think famotidine, ranitidine, which is now off the market. Those are histamine receptors in the gut, and they're responsible for acid production. So the H2 blockers will suppress acid, different pathway, but sometimes can be some cross reactivity there. So we mentioned before, it's the antigens. That's basically, we can kind of use them synonymously with the allergen. That's what triggers the allergic response. I'm gonna gloss over that. We talked a little bit about that, but I'm just gonna go over the big categories of inhalant allergens that we think about. Tree pollen, the trees. Spring is the big time for tree pollen in most of the US. When we think about the trees, you have to think about different families of trees. And when you're allergy testing, when you're deciding, you test for the trees that are prevalent in a given region. So the kind of allergy testing that's done in the Northeast, maybe it's going to be a little bit different than allergy panels in the Southeast or the Midwest or the Pacific Northwest. And it really is driven by the local species of trees and plants. Grasses, big time for grasses. It's the summer. They're among the most potent allergens. There's 3 subfamilies that can be, and we usually test for at least a couple of them. Weeds tend to be prevalent in the fall. Ragweed, perhaps the most well-known of those. And then, of course, pets. So it's not the fur or the hair that people react to in pets. It's the dander. And the dander is the dead skin. It's also saliva, tears, urine can also be allergenic. Are there really such thing as hypoallergenic pets? Probably not. I think, some people do react to certain ones less than others, but it's not the hair, it's the skin. Cat dander is particularly allergenic and sticky. We always test for cats, even when someone doesn't have a cat. If you take a cat out of an apartment, they'll see, you look at that apartment or house 6 months later, there'll still be cat dander. So people are exposed to cat dander, you know, it sticks to clothes, it sticks to furniture. So even when you don't have a cat, you could be exposed to cat dander in other places. It's a very small and particularly, you know, particularly important cause for the nasal, eye, and asthma symptoms. Dog dander, not quite as potent or sticky. And then we also have to always think of other exposures, but I mainly test for those if someone has a known exposure and reaction. Dust mites are a really important allergen. So this is one of the perennial year-round allergens. It's mainly indoors. They're very small, very allergenic. There's two main species of dust mites, but there's a lot of cross-reactivity. These awful looking creatures those are dust mites. Dust mites tend to thrive in warm, humid places, bedding. So that's bedding, pillows, carpets, all of those places. And it's a horrible thing. I read this a couple of places, but that a pillow that's 2 years old, the weight of it could be almost 33% between dust mites and then the dead dust mites and the decomposed dust mites. It's just an awful thought. But they do, it's not even their dust mites are everywhere. They're a fact of life. Other important allergens, roach. We test cockroach dander. It's kind of an important allergen, particularly in urban environments, even for people who've never, said I've never seen a roach. Cockroach, we still test, and it's a common allergen. Molds also very important, but there's so many molds and more than 1 million species. So I think the molds, we do test for some of the very common ones, but I think the molds are a little, I think they can be a little harder to test and treat, just because there's so many. In terms of allergy treatments, what's available to us, avoidance, of course, is very effective, just not always possible. Medications, and then we have immunotherapy. We'll just touch base on all of these. So environmental controls, when it comes to dust mites, we, advise people to minimize their carpet if at all possible, minimizing stuffed animals and extra, upholstery, drapery. Mattress covers and pillow covers, they're pretty widely available at Target, Walmart. They're the allergy proof ones, and they completely cover the mattress and the pillows. I usually recommend that people wash your bedding in hot water. Freezing is another way to get rid of dust mites. Not very practical for bedding, but maybe for a stuffed animal, just popping it in the freezer for a day. Changing pillowcases frequently. Air purifiers, HEPA filters, they can also be effective, but the air purifier, it has to be powerful enough to fit the space that you're trying to treat. So you just have to look for the specifications of the unit. Dehumidifiers can be helpful in terms of minimizing mold and dust mites to some extent. N95 masks are effective, or N95s are going to be the most effective, but even any type of mask. For people, it used to be that, now we probably all have a couple in our N95s in the glove compartment. But for certainly if there's I always advise people that are having occupational exposures, or even if you're allergic to grass, when you cut the grass, wearing a mask can be effective. So when the environmental controls aren't enough, we start to think about medications. And I feel this way when I walk through this aisle in the drugstore too. it's a little overwhelming because there's so many different formulations out there, and they all seem to, different combinations. It's overwhelming. We'll talk about these are the main categories of medications we think about for managing allergies. Steroids, both intranasal steroids and oral steroids, antihistamines, decongestants, think pseudoephedrine, mucolytics, anticholinergics. The anti-leukotrienes they're a prescription, a little less common as the mast cell stabilizers. But we'll talk about a few of the most common ones. Steroids. Steroids work by downregulating the inflammatory response. They bind to this intracellular glucocorticoid receptor, and they actually downregulate the cellular production of those inflammatory mediators. Oral steroids, pills like a prednisone, sometimes can be helpful for a really severe and acute allergy attack, of course, or asthma attack. Not as helpful, in the ongoing treatment for allergies just because of the potential side effects for steroids. Likewise, I think the, intramuscular shot, the steroid shot once a year used to be a little more popular. I think that's fallen out of favor just because we have other medications that are safer and just, a better strategy for long-term management for allergy symptoms. Intranasal steroids, kind of the mainstay for allergy treatment. Fluticasone, mometasone, triamcinolone, budesonide are some of the generic names. I know I'll try not to mention it, but if I mention some brand names, it's just really for the name recognition. Not that I'm endorsing any certain brand, but the Flonase is the generic is fluticasone. That's the generic name for Flonase. We've always used to think of Flonase as synonymous with nasal steroid, kind of like Kleenex and tissue. However, now I just saw in the drugstore the Flonase now puts out some decongestant, some pills that are combination decongestant and a histamine. So the bottom line is you just have to know what medications are in any of these formulations. But intranasal steroids, very effective in treating nasal and eye symptoms. The downside is they don't work quickly. I usually say you have to use them consistently for 5 to 7 days before you can really make a judgment of whether they're providing any benefit. So they are more effective with consistent use. They're safe, low systemic absorption. They are approved for use in children, and some of them are approved for use in pregnancy. So the pretty safe, low risk. Certain people, there is some concern with glaucoma and cataracts, just of the nasal steroids exacerbating those conditions. Nasal steroids can often be used safely, even in someone with those conditions, but I usually just advise someone to check with their eye doctor if they have either of those conditions regarding whether it's advisable for them to use at least a nasal steroid in the longer term. In terms of the technique, the other problem, nasal steroids, sometimes they can cause irritation and nosebleeds in certain people. And the nosebleeds tend to be more problematic if the steroid spray is hitting too much of the nasal septum. So where we want the steroid, this is the lateral nasal wall. So these are the turbinates. I showed you those pictures of those really pale, boggy turbinates in those a little earlier. This is what they look like. So that's the tissue that swells on the side of the nose. So that's where we want to direct the nasal steroid spray. So the correct correct technique is to point out towards, I'd say, kind of aim for the ear there, because you want to get this tissue that's on the side of the nose. You don't want to, we're trying to avoid hitting the nasal septum because that can cause irritation and make nosebleeds more likely. Antihistamines, also mainstay for allergy treatment. First generation antihistamines, diphenhydramine, chlorpheniramine, hydroxyzine, brand name for Benadryl. Those can be very effective. The downside is they're sedating. They have a greater propensity to cross the blood-brain barrier than the second generation antihistamines. The second generation antihistamines, cetirizine, loratadine, fexofenadine, desloratadine, that's your Claritin, Allegra, Zyrtec, and the newer one, Xyzal. All tend to be pretty effective. Some people feel like they get more relief with one than the other. Some people will also say after a while they feel like they need to, switch it up and try a different one, but they're all effective. The advantages is these antihistamines is they work quickly. They can be used on an as needed basis, unlike the nasal steroids sprays that are really more efficacious if used consistently. The antihistamines can be used as needed. There's also topical intranasal antihistamine. So that's an antihistamine nasal spray. Some of these are available even over the counter now. The azolastine is a common one. The antihistamines are good at treating both early, like immediate allergic effects, and the later phase reactions that occur, hours after an allergy exposure. Adverse effects, sedation, mainly with the first generation. There are certain people who are sensitive and do experience some sedation with the second generation antihistamines. I know at least fexofenadine was the one that was approved for use in airline pilots. That probably should have the least sedating effects. But all of the second generation should be less sedating. Some people just find that the first generation, the diphenhydramine, are just more effective for managing allergy symptoms. And it's okay, for a lot of people, I'd say it's okay to take, if you're going to take it and you take it at night, then the sedation's not as much of an issue. Again, just the antihistamines, they work quickly, they can be used as needed, they're widely available, and they're very safe. They're approved in pediatrics. Decongestants are available both in pill form and nasal spray. Sudafedrin is the most common oral decongestant. The topical ones, phenylephrine and oxymetazoline. These are, they're good for nasal congestion. The side effects do have more side effects though. So for the topical ones, the sprays, anybody who's ever used a nasal decongestant, knows that works quickly. It gives that quick relief of nasal congestion. The risk is it's just that it's not a good long-term solution. Basically, the condition, that duration of activity starts to get shorter and shorter with increased use. People start to need them more and more. And eventually the nose, there's a condition, rhinitis medicamentosa. That's what happens to someone's nose when they're using too much of it. And it has a very characteristic kind of appearance of just being really congested and inflamed. So not a good, it's okay. I usually say if you're going to use it, a couple of times a week, probably okay. More frequently than that, not so good. Sudafed oral decongestants, they lead to, they constrict blood vessels, decreased blood flow, decreased edema, more interactions, including people with high blood pressure have to be particularly careful when using oral decongestants. Certainly someone without whose blood pressure is not well controlled, I would advise against that. For well-controlled high blood pressure, occasional oral decongestant use is probably okay, but again, it's probably best to check with your primary care doctor about that before using them. Other conditions, you have to be extra cautious with glaucoma, the monoamine oxidase inhibitors like amitriptyline. They can cause some urinary retention and then risk of stroke. Mucolytics, the guaifenesin, most widely known. These tend to decrease the viscosity of secretions and increase the volume. So not the best, allergic rhinitis, probably not front line, and you have to really use the maximal dose to really even see some benefits. Anticholinergics, ipratropium, this is not really front line. This is more, that's more effective for the vasomotor rhinitis, not so much for allergic rhinitis. The leukotriene modifiers, just the last medication I'll touch on quickly. Montelukast, the brand name is Singulair. It was more widely used in the past, not frontline now. The FDA did put a black box warning on for allergic rhinitis a couple of years ago. It's still approved for use in asthma, but definitely I don't use it as much for allergic rhinitis. The black box has to do with it causing some psychiatric effects in certain people. So allergy testing. So does everybody need to, anybody having allergy symptoms, do they need to be allergy tested? No. Not if the history is consistent and they can be effectively managed with, over-the-counter or even prescription medications. But allergy testing does help us decide if there's, it can help us identify allergens and determine a safe starting dose for immunotherapy, which would be allergy shots. A couple different techniques, prick testing and intradermal testing are both skin testing techniques. And then there's also blood testing for allergies. Reliable results can be obtained with either method. Skin testing, the skin's accessible. There's lots of, most of the mast cells that are, responsible for the allergy symptoms are residing just in the layer right under the skin. So it's a good place to measure reactivity. With any kind of allergy testing results, the history has to be consistent. So you have to interpret all these results in the context of the symptoms. Intradermal dilutional testing. This is the kind of testing where you start off with a really dilute exposure to the antigen and increase the concentration until you see a reaction. This is more of the intradermal dilutional testing. Anybody that has this done doesn't probably remembers it. Lots of little needles injecting a tiny little wheel and then measure the response, measure how much that little wheel grows, and we can estimate, or not just an estimate, but kind of an objective evaluation of how reactive someone is. Prick testing, we do this frequently in the office. This is we're using concentrated antigen, and this little plastic device has these little prongs that you really they kind of indent the skin. It's really not breaking, this isn't the kind of, these prongs aren't drawing blood. So that's kind of like it just gets under the skin. And so you're testing all of those, we can test like 32, all at the same time. It only takes about 15 or 20 minutes. So it's convenient. We can plan immunotherapy based on these results. So prick testing tends to be our, first line test for skin testing. We can go on to intradermal if necessary. This is just an example of a prick test. So that little device gets rocked back and forth on the skin. We have we know exactly which antigens are which. And then at 15, 20 minutes, we're measuring and measure the wheel, measure the size. And then we have positive and negative controls. We actually inject one of the positive controls is histamine. And so we're comparing, how you compare the reaction of these to the reaction of the histamine. You have to stop all antihistamines 5 days prior to skin testing because that will interfere with the results. And, antihistamines are present in lots of these. These are just over-the-counter medicines. that contain some sort of antihistamine. Contraindications, poorly controlled asthma, because there is some risk of inducing causing an asthma attack or even an anaphylactic response with skin testing, because you're actually, purposefully exposing someone to an antigen. Well-controlled asthma, skin testing is okay. Certain types of non-selective beta blockers that are used for high blood pressure. I already mentioned antihistamine use, dermatographism. That's somebody whose skin reacts to anything. So the blood test, also a reliable way to test for allergies. The advantages of the blood test: it's safe. We're not intentionally exposing anyone to an antigen. There's no need to stop medications. It can be used to plan immunotherapy. The downside, you have to wait a few days to get the results, probably more costly, and potentially we tend to be as a measure of safety when we're planning blood testing. We start immunotherapy at a kind of a lower dose, so it possibly could take longer for escalating. So the general principle of immunotherapy or allergy shots is that we're basically retraining the immune system, and you're trying to induce an immunologic response by exposing a person to whatever antigens they're allergic to, which alters their T cell responses, restore that Th1, Th2 balance that we talked about a little earlier. And it's actually, done, it's the immune system produces different kinds of antibodies that can then basically compete with the IgE. So the principles, we're intentionally exposing someone to specific antigens. The specific antigens are identified as, on the allergy testing. It requires regular dosing, which usually means a weekly injection, at least for a period of time until you get up to a maintenance dose. So allergy shots are usually about a 3 to 5 year commitment of pretty regular appointments. And during that time, the dose is progressively escalated to the concentrate, which is the max, we think of it as the maximal dose we're trying to reach. And of course, the primary consideration is safety, avoiding unacceptable local and systemic reactions. So immunotherapy can be given with shots, or there are certain sublingual immunotherapies that are FDA approved. There's a sublingual therapy for dust mites. There's one for grass pollen and ragweed. So, that when someone's really only kind of allergic to the one or has limited sensitivities, those are good options. There are allergy, there's sublingual allergy serum can be mixed from the same way we mix shots, but that's not, it's an off-label use and it's not covered by insurance, but it's still an option. And certainly we do have patients receiving immunotherapy via the sublingual route. That's a whirlwind tour of allergies. There's my family in a very non-allergenic place, and my dander shedding pet here, just for some interest. And we'll take any questions.
Dr. Hathaway, thank you so much. And we have a ton of questions.
Oh, good.
So let me start. Is it common for new allergies to begin in adulthood or middle age?
Allergies can start they can start anytime. And just like some people have allergies when they're younger and seem to outgrow them, you can develop new sensitivities. And the immune system, it's always, the immune system is always changing. And there certainly are people, who have an atopic there are people who are certainly just prone to the atopic diseases. All of the atopic diseases, the allergy, the asthma, the eczema, they tend to go together. And so there are people who just have that propensity for allergies, but new allergies can start
at any time.
Yeah.
So this is an interesting one as a follow-up. Can allergies be outgrown?
Yeah, I think the immune system, the immune system can change. And so, yes, I think that, do we understand why some people, why some people outgrow their allergies and others don't? I don't know. Can it be a matter of exposure or but yeah, no, allergies can definitely change with time.
So this is interesting. Do you expect to see more kids with allergies because of lack of exposure during COVID isolation?
I've thought about that because, and I think that it'll be interesting to see what happens. I mean, when, kids weren't exposed to anything for, kids that were for those first couple of years. And we'll have to see what happens in the coming years. I mean, I think, we already saw a bit of that with this respiratory season, just how hard kids were hit with all different, respiratory viruses because they hadn't been exposed for several years. But yeah, we do, it's pretty well established that less exposure in childhood leads to more, atopic disease in the future, as young adults and adults.
So if you have food allergies, are you also more susceptible to airborne allergies?
There are different types of, food allergies. That's kind of a whole nother topic. And there's different food allergies. So, there are the IgE mediated allergies. There's the ones that result in, anaphylaxis. And we kind of know those, that's like your shellfish allergy. That's So food allergies cause a whole range of allergy symptoms. There's something called oral allergy syndrome where people have mouth symptoms. It's often after eating certain, fruits tend to be a big cause for that. And so there are certain ones do, like I said, the allergic diseases, they tend to cluster together. Which ones will manifest in a person is unpredictable. But yes, I mean, even like the eosinophilic esophagitis wasn't a thing. It's probably really only been really well recognized in the past 20 25 years or so. Years ago it wasn't even recognized, but now it's well recognized that there are that food allergies probably is particularly in childhood play some role in that. So yeah, they do. The allergic diseases tend to cluster together, but food allergies, there are different types, whole range of symptoms.
So on that note, and this is a question from me, what about allergy-induced asthma?
Is your question, are you more likely to have?
Well, can you talk about allergy-induced asthma? Because I know that there are a lot of people in middle age who are getting allergy-induced asthma.
So there is some evidence that treating, aggressive allergy treatment in childhood can prevent the, development of asthma later on. So that there is definitely some evidence that we can prevent the progression, that maybe you can prevent the progression to asthma. Now, adult onset, it depends. I guess it really has to be established that it is allergic.
Correct. Yeah.
Because there's other types of asthma that are also common in adults and other things that can mimic asthma in adults. So I think that it really would have to be, well established that it's allergic asthma as opposed to another cause for asthma.
Gotcha. Can untreated allergies lead to sinus infections?
So, that's a good question.
Yeah.
So Sometimes, yes. No, so if you think that there's always a debate, there's a debate in the sinusitis world about how much allergies are to blame. And
Mhm.
that's because sinusitis is such a heterogeneous disease. And so I think sometimes allergies can be a trigger in terms
Mhm.
of if you have so much congestion in the nose and things aren't draining, yes, it could be a setup for for an infection. However, I think the other important thing to think about is sometimes people will come and say, well, I get a sinus infection every spring, or I get a sinus infection every fall. But it might not be a sinus infection. It might be a flare. It's always difficult to determine, is this an infection or is this a flare in allergy symptoms? So there's a relationship, there is some relationship probably between allergies and sinusitis, but even it's always it really comes down to history, response to medications, but it's a challenge sometimes trying to figure out, is this an infection or is this an allergy flare?
So how do you, another question, and it leads into this one, how do you know? I mean, is it, how easy or hard is it to distinguish between seasonal allergies and a sinus infection?
Well, so sometimes it's straightforward and sometimes it's not, because a lot of the symptoms, they share a lot of the same symptoms.
Yes.
Congestion, runny nose, facial pressure. So some of it comes down to response to medical therapy, whether it responds to
Mhm.
the anti-inflammatory allergy type.
Mhm.
It's a combination of, how response to therapy when it's unclear. Sometimes certainly allergy testing then plays a role. And then that's when that's when seeing an otolaryngologist becomes really helpful, because we have the equipment, we can look in the nose, we can do a culture, sometimes we can, with an endoscopy and culture, establish whether something's an infection, sinus imaging. So there's a lot of tools in terms of it comes down to the diagnostic, response to medication, additional diagnostic studies, be it allergy testing, culture, imaging, like a sinus CT. It's sometimes it's not easy, and it's not always the same, just because it's an allergy flare one time doesn't mean that it can't be a sinus infection another time.
Right. Right. So is there a hereditary component to allergies?
Yes. So yeah, there is, and that's true for the atopic disease.
Mhm.
The atopic diseases do tend to have a hereditary component.
Okay. Are there any new allergy medications or treatments on the horizon?
So new allergy medications and treatments. There are some different, and thinking about just some adjunctive procedures that are done. There's a procedure that's done called the Clarifix. It's a procedure basically doing cryotherapy to one of the nerves in the back of the nose that stimulates to prevent the mucus production and congestion.
Mhm.
More effective for vasomotor rhinitis symptoms than allergy symptoms. Are there new allergy? I think there's multiple areas in the pathway. When you think about all the different inflammatory, there's a lot of different, we think about the antihistamines and the steroids, but there's many different spots pathway where, where you can intervene to have a positive effect on allergy symptoms. So yes, I hope so. Yes, the answer is yes, but
Yes.
not
Okay.
quite there.
So is there a difference in approach between traditional allergist and otolaryngologist in the treatment of allergies? Any reason to see one rather than the other? Good question.
It's a good question. So I think the principles that we rely on are the same in terms of that hierarchy of avoidance medication. The way, there are some subtle differences in the way that traditionally that will mix, when it comes to mixing formulations for immunotherapy, there are some subtle differences in that.
Mhm.
I have a very, I tend to work together with the allergists a lot. We work together. There are certain conditions where I tend to rely on them more, for certain conditions when it comes to difference, some systemic react, certainly with, foods, or there's, certain systemic things like recurrent hives or angioedema. So I think there are certain conditions that we collaborate a lot. I think that the advantage of seeing, with otolaryngologists, we have more expertise with, examining the anatomy, being able to, look in the nose with endoscopes, interpret imaging, evaluating for conditions other than allergy, infection and that type of thing. So I think that there's definitely a role for both. I mean, I like to think as an otolaryngologist, we have a lot of other, we have a lot of tools in the toolbox with being able to really look and see what's going on. But I collaborate with my allergy colleagues all the time, and I think that they do very good, work with people in terms of, immunotherapy and medical therapy.
So we're going to end on, it's more of a comment than a question. Love Dr. Hathaway. She's my ENT. Great presentation. So on that note, Dr. Hathaway, thank you so much for today. And to all of you who joined us, we will be back in 2 weeks with an ophthalmology presentation. As always, thank you for joining the Eye and Ear Foundation for our lunchtime webinar. Thank you, Dr. Hathaway.
Thank you.